Assalamu alaikum. Good morning, good afternoon, and good evening. I hope everybody is doing great. Uh, Today we are going to discuss uh, about gastroenterology topics. Today we are going to cover dyspepsia, gastritis, and PUD. We will cover a little bit about the H. pylori and also stress gastritis or stress-induced ulcer. So dyspepsia, we're going to cover the definition, red flags, gastritis, the types, how many types do we have, the key clues, peptic ulcer disease, the diagnosis and treatment, H. pylori, non-steroid anti-inflammatory drug-induced gastritis, stress, and also high-yield approach. So let's start it. The first one that we are discussing is dyspepsia. Dyspepsia is the core definition and symptoms pattern is predominant epigastric pain and burning lasting at least 1 month. So remember that if they are going to test you about dyspepsia, they would definitely mention that the patient is having epigastric pain and burning, which the patient has been suffering for at least 1 month. This should give you an idea like what is the station and what I'm dealing with, and based on that, you map out your approach. So for those of you who are preparing for the licensing exam, always remember the timing. Okay, if they want to test you on dyspepsia, they may mention the timing. Other dyspepsia symptom, which is very common, mentioned as a clue in the scenario on top of the epigastric pain and burning, is the postprandial fullness and early satiety. These are the two other or additional symptoms that they will definitely mention it as a clue to help you to kind of think or pay attention to dyspepsia. Most cases are functional. What do we mean by the functional? Functional is actually a maldigestion. It's a maldigestion that it mimics dyspepsia and gastritis and GERD sign and symptom, but it is not actually to that level or that stage. So it means if you're dealing with any patient who has epigastric pain and burning sensation or burning pain in the epigastric area, and also the patient has fullness and early satiety, so the first most important thing to rule out is the functional one. If the patient has maldigestion, so what happens, the food is not getting digested, so the patient have what? Early satiety. The patient will have bloating. The patient will have fullness and discomfort, epigastric discomfort. So this is something that you have to rule it out. And when you're doing the station, you need to verbalize this. Make sure that the examiner knows that now you are working on something to rule out the functional. If you think that you could not convey the message, you can even mention it. Now I would like to focus on ruling out the functional, or this is something that I have to take care first, then move on to the most concerning or serious conditions. In practice, the differential becomes more urgent if you have a patient who has these signs and symptoms, which is called warning sign, and that's the main reason I made it red and I made it bold so that it stands out a little bit more than the other part. Vomiting, weight loss, or any other ominous feature, which is like stricture, right? So these are the things that you need to pay attention when you're differentiating, because these things are urgent, or they are priority number one to be mentioned. High yield risk factor. So in terms of age, pay attention to the age of your patient. If you're dealing with something, like if the patient ages anything above 60, like if you're dealing with 69, 68, 67, anything above 60 should raise your eyebrow. Like this is gonna be a little bit challenging. Why? Because the chances of having complication or chances of having a functional dyspepsia is much less, but something like malignancy, something very serious like ulcer, bleeding, and all that is higher. So these are high yield risk factor. Associated sign and symptoms. Obviously, we have to ask about constitution sign and symptom in any station. In any station, when you're covering the first part, which is obviously the OCD, PQRST, AAA, UV AAA, in case of pain, or another case, depending on the condition, whatever it is, once you're finished, the next thing that you need to do is review of system, constitution sign and symptom. Then you jump or transition into past medical history, family history, and social history, and then you summarize it. So do not forget the constitutional that you need to ask it right after review of system. Okay? And drug history, obviously very important. You cannot forget about it in any station. Usually we ask about the specific drug and the past medical history. Just to remember how to ask the past medical history, it's going to be really long if you think about it, but if you want to remember it and make it very easy to remember, just remember the mnemonic which says SAT. Maybe I should write it down here. For the past medical history, just remember this mnemonic, SAT. So S stands for surgery, A stands for allergy, D stands for drug. So in any station that you're dealing with history, please do not forget that you need to cover SAT in the past medical history. Surgery, allergy, and drugs, especially if you're dealing with gastroenterology topics. So why? Because something that we are getting over the counter is non-steroidal anti-inflammatory drug. And that is the main reason for most of the gastritis that we face or encounter in our professional life after H. pylori. So the first most important cause for any ulcer is H. pylori. The second one is non-steroidal anti-inflammatory drug. So you cannot afford to forget it. Now, alarming feature investigation for that. If you have alarming, like if you have these, if you have constitutional sign and symptom, then you have to do further investigation or escalate. So it could be unintentional weight loss. It could be, as I mentioned before, vomiting, dysphagia, odonophagia, unexplained iron deficiency, if your ferritin is low, if your vitamin B12 is low, hematomesis, jaundice, palpable abdominal mass, lymphadenopathy, family history of upper GI bleeding or GI cancer, previous gastric ulcer. So these are the things are alarming. Just to make it very simple, I put it here, but these are the alarming. If you have any of them present, then you have to escalate. It means you need to do further investigation or you need to do endoscopy. Because for all the dysphagia, for all the dyspepsia, we're not going to jump into endoscopy unless the patient has all these sign and symptom. Or you might get a question as a post-encounter question. For example, your patient, do you order endoscopy for your patient? So now, if you think that yes, you have to do it as part of your investigation, you need to justify it. Yes, I would like to order endoscopy because my patient had some alarming symptoms, and this was this. So you need to justify the investigation that you are ordering for your patient. Now, dyspepsia, focused history and exam, initial investigation, and NAC OSCE take-home message. So for the focused history and exam, clarify dominant symptoms. So what is the dominant or the chief complaint? Burning, pain, burning versus fullness, early satiety, which one is dominant? Screening for weight loss, vomiting, medication triggers, and age-related risk, which we did mention it. Exam clue, adenopathy, abdominal mass, or organomegaly. Carnage sign may suggest abdominal wall pain. If symptoms increase during muscle contraction, That's why usually we ask the patient to raise their head to see if that's positive or negative. So initial investigation, CBC, liver enzyme, calcium, H. pylori serology in the notes that we have, ultrasound when clinically indicated, key endoscopy points. Gastroscopy is recommended at age 60 or older, and in selected patient younger than 60 when the cancer risk or other concerning features are present. If you guys remember, I was insisting on age. Age is uh, one of those factors that when we start the station, it starts with age. So it means that's one of the factor that always we have to keep it in mind, because it really helps us to basically come up with the right structure or approach for our management and for our treatment. So if your patient is anyone who is at any age, regardless of the age, if the patient has alarming symptoms, we need to do endoscopy. But if the patient does not have alarming symptoms, we usually do not jump into endoscopy. But if you happen to have somebody, for example, an elderly, this might be in the licensing exam, actually, for the MCQ one. If you have anyone above 60 and the patient has anemia, you need to do endoscopy. So it doesn't have to have, like, the patient does not have to have pain in order for us to order endoscopy. We can order endoscopy if we suspect anemia in elderly. And also, obviously, if the patient has sign and symptom, then above 60, we need to do endoscopy. Do not label every patient with gastritis. In OSCE counseling, explain the most dyspepsia is functional. This is something when you are summarizing or when you are giving your feedback for the examiner, this is how you go about it, okay? So we do not label every patient with gastritis because in most cases it could be functional or acid-related, but alarming features change the pathway and require further workup. So in my patient, I think the patient did not have any alarming symptoms and the patient has mild digestion rather than gastritis, or the patient has gastritis not functional. But it means that we do not label any patient with a epigastric pain or burning or early satiety or fullness with a gastritis, unless it is one. So gastric physiology and acid regulation, obviously, these are the things that you need to memorize. Cells and gastric mucosa, the parietal cell, the HCl and intrinsic factor, chief cells, D cell, G cell, superficial epithelial cell. So these are the things that might be tested in the MCQ1. So probably they might ask you that which one of these, maybe I should come here. So in the clinical interpretation, high yield link, understand acid regulation, explain the PPI or the backbone of the peptic ulcer healing, and why the non-steroid anti-inflammatory drug, loss of the prostaglandin weakens the mucosal defense. So in the licensing exam, if they want to test you about these cells, and the hormones or the chemicals that makes things worse or better, one of these would be in the licensing exam. For example, histamine, acetylcholine, and gastrin, or all three of them are increasing the parietal cell acid output, and they causes what? They cause what? Hyperacidity. So maybe I should uh, put this. Yeah. So, and they increase the acidity. So keep that in mind. Sorry. Now, main stimulants and inhibitor. Histamine, acetylcholine, and gastrin stimulates parietal cell acid secretion. So what happens if they are stimulating? The acid will increase. Now, somatostatin and prostaglandin. So remember, the somatostatin is released by the D cell. Somatostatin and prostaglandin reduce the acid output and supports the mucosal protection, which this one is being destroyed by using nanosteroid, right? So nanosteroid will decrease the prostaglandin and the protective defense of the mucosa will go down. PPI inhibit the hydrogen potassium ATPase protein pump. H2 receptor blocker reducing the histamine drives, but remember that if they are asking you which one is the most effective, always go with the PPI. This is not as effective as PPI. Now let's talk about gastritis, types, clues, and the treatment principles. Definition: it is histologic inflammation of the stomach mucosa. So in terms of types, acute, erosive, hemorrhagic, gastritis, and Helicobacter. The chronic, non-atrophic, atrophic, chemical radiation, lymphocytic, eosinophilic, granulomatosis, and other infection forms. So we have acute and we have chronic. Now, common etiology of gastritis. What is number one? H. pylori. So this, if you're dealing with any epigastric pain or GI system, you need to ask this, especially if you're suspecting about PUD. Non-steroid is supposed to be the second one. So what does it mean when we say non-steroid? Remember when I was talking about past medical history, I said that cover SAD or SAD, surgery, allergy, and drugs. So remember when you're asking about, let's say you're dealing with a PUD, you have suspected PUD case, and you're asking the patient about the past medical history. So you ask, are you currently taking any kind of medication? The patient says no. Do not just stop right there. For condition like this specific, you need to be very specific. How about over the counter? How about painkiller? See, why? The reason I ask this, for me, when the patient says that he is not taking any medication, I think that I covered it. I already covered it. And this is the common mistakes that cost you a lot of mark and a score. The examiner has to know that you're going after non-steroid. Now, your job is to make sure that he hears you or she hears you that you're going after a specific medication or drugs. Like that is the non-steroid anti-inflammatory drug. That is the steroid itself. And especially if it is for a long time, right? So let's say you have a patient and you're asking, are you currently taking any medication? The patient says no. So if you move on to the next part, you lost like 3 to 4 points. He might give you one, but one doesn't do any good to you. You lost already 4 points, right? So you need to be very specific. And you have to let the examiner know that now I'm asking specifically about the non-steroid anti-inflammatory drug. But how do you do it? How about over the counter? The patient says no. How about the painkiller? The patient says, oh yeah, I'm using my grandma's painkiller when I need it. And how often do you need it? I need it like every 2-3 hours. Can you tell me the dosage? I don't know, but I think it is 600 something. So the patient is taking too much non-steroid anti-inflammatory drug. He's not buying it. He is eating or he is using his grandma's painkiller. I know the cause is drug-induced gastritis. Okay, so this is something that you have to know. Please go after a specific drug. Don't just rely on that generalized or mentioning generally drugs or medication. So alcohol is something that you have to mention, and don't be shy. You have to be very direct. Ask about alcohol. The bile radiation, celiac disease, food allergy, TB, syphilis, fungi, and parasites. These are going to be the etiology or common etiology. Clinical purpose, non-erosive, and we have erosive. All right. So for the non-erosive, is often asymptomatic and usually does not itself cause the pain. And what do we do for the treatment? For the treatment, we usually ask the patient to use the PPI as needed. So we don't put the patient on continuous PPI forever or for long term. But for erosive, that's a different story. Why? Because erosive may bleed and it is visible endoscopically with endoscopy. So it means chances of this to turn into an ulcer and progress to malignancy is higher. So in this case, this patient is going to take the PPI indefinitely. Okay? Erosive, indefinitely. Non-erosive, the patient takes PPI as needed. Treatment depends on etiology and includes avoiding mucosal irritants such as alcohol and non-steroidal anti-inflammatory drugs. Peptic ulcer disease, essential framework. So definition, common cause, PUD is a mucosal defect that penetrate the muscularis, mucosa, and scar. Include gastric and duodenal ulcers. So these are the two things that we are going to discuss and talk a little bit more about it. But the good thing is, not the good thing, but for us, the good thing is that we don't have to memorize so many things. It's the same thing for the, regardless of the PUD, the location, the H. pylori is the first best common, and the non-steroid is the second most common reason for ulcer, regardless of the location. So physiological stress, Zollinger-Ellison syndrome, idiopathic disease. Alcohol damage mucosa, but rarely cause the ulcer by itself. It could be a trigger, and it could be a precipitant. Clinical pattern, dyspepsia is the most common presenting symptoms. Remember this might be in the MCCQE1. What is the most presenting symptom? The most presenting symptoms of PUD is dyspepsia, but most dyspepsia is not ulcer disease. Okay, many ulcers are asymptomatic until they bleed, perforated, or obstructed. Smoking worsens the ulcer. What does it mean? It means if I know this, if I know, but I do not include it in my consultation, it means this is going to be a huge loss for me in terms of score. Huge loss. So it means I cannot forget about alcohol. I cannot forget about alcohol and history. So it means I have to cover the social history. Alcohol and smoking. So I cannot forget it in history taking, and I cannot forget about alcohol and smoking while I'm doing the consultation. Okay, very important point. Do not forget, we are not only focusing on medication. We're not only focusing on which type of medication should be prioritized for you. Beside that, what else can we do to speed up the recovery or support the PPI to do its job better? Okay, so that is alcohol, caffeine, and smoking. These are supposed to be brought up while you're doing the consultation. So smoking worsens the ulcer risk, complication, and healing. Complication, bleeding, perforation, gastric outlet obstruction, posterior penetrating causes pancreatitis. That's why if the patient with PUD, remember this, if the patient with PUD has a pain in epigastric area that radiates to the back, it means the pancreatitis is also present. Okay, so they might test you. I have seen it once or twice in a, I cannot name the subscription, that the patient had PUD, but the pain was radiating to the back. So it's not because of the PUD, it's because of the PUD that causes the pancreatitis, and pancreatitis pain radiates to the back. Gastric versus duodenal. This is very interesting. Remember that how they gave you the scenario. I'm gonna try my best to make it very simple to recognize and pinpoint which one is which, okay? So for the duodenal ulcer, burning epigastric pain, often 1 to 3 hours after meal, relieved by food and antacid, may wake the patient from sleep. And usually, if they give you a scenario about duodenal, they usually give you a scenario about someone that who is a little overweight. And now I tell you why it is going to be a little bit overweight. Remember that the patient usually eat a lot in order to control the pain. So it means if you have a duodenal ulcer in your patient, or if they give you a scenario, let's say they give you a scenario about someone that who is, let's say, 45 years old, and the patient is a little overweight. The patient says that she has epigastric pain that relieves by eating, and it comes back every 1 to 3 hours and makes the patient to eat in order to control the pain. And also sometimes it awakens the patient early in the morning or at the middle of the night. So it means the patient has to wake up and eat. So what happens when you eat a lot? You get more weight, right? You gain more weight. So usually, directly or indirectly, they will mention an overweight patient with a duodenal ulcer. For example, I'm going to give you an example. Let's say you have a patient, your patient is 40 years old, and the patient is 95 pounds, and the patient have epigastric pain that relieves with eating, and the patient sometimes wakes at the middle of the night due to pain. And when she eats something, she gets a little bit better. And also when she uses the antacid, that also helps. So what is your most likely diagnosis? So I have somebody who is 45 years old, and usually female are shorter than male, right? So they're supposed to be somewhere between 50 to 60 kg, and the patient is 95 kg. So it means the patient is overweight, right? So overweight, the patient is eating every 1 to 3 hours and wakes up the patient at the middle of the night. So my patient has duodenal ulcer. Now, on the contrary, the gastric ulcer, more atypical symptom. It's a little bit different. Now, I can add those specifics. So usually the patient have pain with eating. Like the pain starts as soon as you eat. As soon as. Why? Because the ulcer is in the stomach, right? So as soon as the food touches the ulcer, the pain starts. So what happens if you eat and have pain? You avoid eating. You try not to eat. So what happens if you don't eat? You lose weight, right? Now, in this case, if they give you a scenario about gastric ulcer, they usually give you a scenario about someone that who has lost weight. Not because she has or he has cancer, because the patient is afraid of eating. Because with every single bite that he takes, the pain worsens. That's why the patient avoids eating altogether and the patient loses weight. For example, let's say you have a patient, 45 years old, male, smoker. The patient is having epigastric pain that worsens with the eating, and the patient is uh, 52 kg or 55 kg. So male, 45, usually male are, let's say, 5'11" or 5'10", 5'5", right? The least 5'6". They are supposed to be anywhere above 60. So if they're less than 60, they are 10, right? So now it says that the patient has lost weight. And why do I think that my patient lost weight? Because my patient is afraid of eating. It indirectly mentions that when the patient eats, the pain worsens. So this is how they're gonna give you scenario, and you should be able to differentiate it based on the scenario. I'm not saying that you don't have to do endoscopy. In this case, you have to do the endoscopy, but clinically, at least you know I'm dealing with a duodenal ulcer or I'm gonna deal with the gastric ulcer. High yield. Most gastric ulcer are biopsy, duodenal ulcer are rarely malignant. So another difference is that rarely, rarely malignant. But this one is, uh, I can't say mostly, but uh, malignancy more than duodenal ulcer. Maybe it makes sense. Okay. So it means the malignancy is more common in gastric ulcer, but malignancy is less common in duodenal ulcer. All right. So in terms of investigation, endoscopy is the most accurate. As I mentioned before, this is the most accurate. So remember that we have most accurate test for the reflex, which is the pH, but most accurate test for ulcer or PUD is endoscopy. Upper GI series is another option in selected setting, or the H. pylori test. Consider fasting gastrin as Zollinger-Ellison syndrome is suspected. Treatment, sorry. Treatment approach, treat H. pylori if present to prevent recurrence, stop non-steroid if possible. Remember, we have to ask the patient about non-steroid, and if the patient has it, obviously in a consultation, that should be part of our consultation to make sure that the patient is stopping the non-steroid anti-inflammatory drug if possible. Remember, if it is not possible, the patient can take the PPI and the PPI is good enough. It will take care of it. So you don't have to worry. But if the patient can stop it, they have to stop it. For example, if the patient has rheumatoid arthritis, so he can stop it, right? So in that case, just continue the PPI and continue the non-steroid anti-inflammatory drug. Start PPI, the key healing therapy, it's less effective. Stop smoking. Obviously, these are the things that we have to pay attention when we are doing the counseling. No universal diet restriction. We do not, like, usually everybody thinks that, oh, you have gastritis, so you don't eat this. There's so many things that there's nothing left for us to eat, right? So there's no universal diet restriction, but avoiding a few things like caffeinated drinks, alcohol, and spicy food helps. Doesn't cure, helps, supports the treatment. Approach of PUD, stop non-steroid and PPI, eradication of the H. pylori, quit smoking, mortality in bleeding ulcer, rises with coexisting illness, hemodynamic instability, age more than 60, and transfusion required in severe cases, obviously, or elderly. H. pylori diagnosis and eradication. So I think everybody knows about H. pylori. It's very popular in third world countries, like country like mine, Afghanistan. It was something like if I was visiting 40 patients a day, 20 of them had the H. pylori. But in Canada, it is 20%. So it means if you're visiting 100 patient of gastroenterology cases, 20 of them will have the H. pylori. But back home, it was like 50-50 or more, in some cases, even more than 50. So gram-negative flagellated organism and causes persistent gastric infection and inflammation associated with the peptic ulcer disease, gastric carcinoma, and mucosa-associated lymphoid tissue lymphoma. 20%, as I mentioned, and testing practical ranking. So non-invasive, and then we have invasive. So what are the things that we are doing as an investigation for the H. pylori, which are non-invasive? Remember, in MCQ1, they might mention what are the golden standard invasive investigation or approach for this patient. So they give you a clinical picture of somebody that who has H. pylori, and they are specifically asking you about the invasive golden standard. So in that case, you go ahead and do the biopsy. But if they're asking you the non-invasive, it is urea breath test. High sensitivity, specificity, PPI. Remember that it can falsely be positive, negative, sorry, or it affects in general the result of the test. Serology cannot distinguish active from the past infection, not used for cure confirmation. So it means we used to do back home. I don't think we still have it back home in Afghanistan, the urea breath test. So what we do the serology, and we do for the result, we do the stool exam. But some of the IMGs, they mistakenly go ahead and choose the serology for the result as well. So it is not used for the result or for the cure of the H. pylori. So if they're asking you, most likely it will be what is the best and most sensitive test for H. pylori? That will be the urea breath test. Okay. And if they're asking you about the invasive, golden standard, histology, rapid urea test is fast. Culture, we don't do it. Eradication and exam pairs. So now this is the treatment. They might give you a few options, and the best option is the Bismuth quadruple therapy recommended for the 14 days. It used to be a triple therapy. Now it is the quadruple therapy, which is the PPI, the Bismuth, and metronidazole, and tetracycline. So this is very commonly used and the first best choice H. pylori eradication regimen. Okay, so we have Bismuth and we have non-Bismuth. So the Bismuth, the beauty of the Bismuth, if you ask why they add Bismuth, is because amoxicillin and clarithromycin are two agents that they are causing diarrhea. That's why they are not using it commonly as before. They used to use it as a triple therapy, and it was causing everybody with H. pylori to come back with a very severe diarrhea. And the chances of colostrum difficile was getting very high. So they came up with this. And the beauty of Bismuth is that it also controls the diarrhea. Serology should not be used to confirm the eradication. Again, do not use it. And let's move on. Non-street induced and stress-related ulcer. For the non-street, obviously, it is decreasing the prostaglandin, and prostaglandin is protecting the mucosa. So once it is low, the bicarbonate secretion and mucosal blood flow will lowers, and the patient will be exposed to, will be at risk of ulcer and gastritis. Risk factor: previous ulcer, upper GI bleeding, age more than 65, older or older than that, high dose of non-steroid or multiple non-steroid, steroid, major comorbids. Non-steroid, always we try to stop it unless for some reason the patient cannot stop it. In that case, we can just go ahead and continue our PPI. So lower the dose or stop the non-steroid when possible. Again, acetaminophen, we can always change it to that. So this might be a question as a post encounter question, or it might be one of the MCCQE1 question. And enteric-coated aspirin. So let's say you have a patient, and your patient, or you might get a question from the patient. The patient has non-steroid induced gastritis or ulcer or PUD, and the patient is having, let's say, rheumatoid arthritis, and the patient is using aspirin and ibuprofen for the treatment. And the patient is saying that, how about if I change my aspirin to enteric-coated aspirin? Does it decrease the risk of ulcer? What would be your question? Or it will be one of the post-encounter question by the examiner. It can reduce the erosion, but not the ulcer risk. So remember it for both NACOSKI and MCQ1. That's why I made it red. A stress-induced ulcer or ulceration occurs mainly in critically ill patients. So a very common mistake by IMG when we are saying a stress ulcer or a stress gastritis, they think that we are talking about emotional or psychological stress. It is that, but usually when they are asking about ulceration, is about the very critical condition that the patient is under a tremendous amount of physical pressure and stress. For example, the most common clue that they might use is mechanical ventilation. Who is going to be connected to mechanical ventilation? Obviously, somebody who is in coma. So if you're in coma, something bad happened physically, something bad happened to you, right? So it could be a very severe trauma, it could be a severe burn, it could be a severe injury, it could be a very severe illness that it pressures so much your body that your body does not get enough of the blood in that area. So that area is kind of slowly starts to decay. And other risks could be anticoagulants, multi-organ failure, septicemia, severe surgery trauma, CNS injury, major burn. So for the burns, they might not mention it directly, but indirectly they will mention something like, let's say, 30 or more than 30% of, sorry, 30 or more than 30% of body surface area burn. So this on its own should tell you that that's a major burn. Okay. Usually presents with a painless upper GI bleeding. PPI prophylaxis is strongest when may increase pneumonia risk. H2 blocker less potent. So we did talk about this. All right. So for the bleeding peptic acid emergency approach, what do we do? So ABC vitals including orthostatic changes, CBC electrolyte, BUN, creatinine, INR type, and cross-match. Please remember this. This will be in the NACOSKI station, especially if you have an emergency case of bleeding PUD. So resuscitate with the crystalloid and blood products when indicated, IV pantoprazole and urgent endoscopy. Suspect bleeding, resuscitate. Plus IV pantoprazole. Endoscopy, high risk or low risk. If it is high risk, CLIPS, thermal coagulation, plus minus epinephrine, continue IV PPI, monitor for rebleeding, and consider ICU depending on the severity. Low risk, no endoscopy, treat as an outpatient. Okay, after endoscopy, what do you do? These are the things that might be as part of your post-encounter question, or it might be in the MCCQ1. Please remember this, especially this part, which it says resume clear fluid after 6 hours. I have seen it in so many subscription, so it might be also one of your question in the licensing exam. Okay, so after endoscopy, resume clear fluids after 6 hours. Test for H. pylori, non-steroid, antiplatelet, repeat the endoscopy if rebleeding, then involve interventional radiology or surgery if needed. All right, this is very long lecture. Okay. So one slide for one station. Let's say if it is a dyspepsia station. So common IMG station plus exam. Example. So the common station could be an outpatient assessment of the chronic epigastric pain or burning. Example, 42-year-old with 2 months of post-meal epigastric discomfort asking whether this is an ulcer or a stomach cancer. That's it. This is what you get in the instruction. So common IMG test. It could be focused history, red flags. So focus, you take a focus history, red flags screening, medication review. Do not forget about medication. Explain initial management. Decide who needs early endoscopy. So it means that we do not have to use endoscopy for everyone unless the patient has alarming sign and symptom. So this is what the examiner expects you to know. Now, heavy scoring points, when you're doing this, what are those points that secure you a lot of score? Define the syndrome clearly. What is dyspepsia? Predominant epigastric pain or burning, often with the early satiety or postprandial fullness for at least 1 month. Ask about duration. Why duration? Because it is at least 1 month, right? Relation to meals, non-steroid, alcohol, smoking, and prior ulcer history. So basically, you're covering the OCD, PQRS, UV, AAA. You don't have to go one by one if it is not just the pain, but if it is the pain, you need to do it. Actively screen for alarming features. So we did go through all alarming symptoms that you need to cover in order to make sure that if the next question is, what do I do next? Do I have to order endoscopy or not? This is why we have to cover the uh, alarming symptoms. Unintentional weight loss, so on and so forth. I'm not going to talk about it because we did cover it, right? If it is positive, endoscopy. State the high yield plan. In patient without alarming feature, think functional dyspepsia. Review the drugs, consider the CBC, basic labs, and H. pylori strategy. Use acid suppression appropriately and arrange gastroscopy for the older age. If the patient is over 65, but if the patient is less than 65 and the patient does not have the red flags or alarming, forget about endoscopy. Pitfalls. So these are the things that you should be avoiding, okay? Do not label all epigastric pain as gastritis. Dyspepsia is a symptoms complex, not a final diagnosis. Do not miss medication cause. So do not miss medication causes, especially non-steroid and aspirin, or ignore extra gastric causes such as pancreatic or biliary disease. Okay. Do not reassure too early when the red flags are present. So it means you need to take it easy and go ahead slowly. Now, peptic ulcer. Now, this slide is exclusively for a station that you might get about peptic ulcer. So, common station, patient with epigastric pain or upper GI bleeding. For example, a 58-year-old patient with a melena and non-steroid anti-inflammatory use, or a younger patient with a nocturnal epigastric burning relief by food. So the last one we know, what is that? Duodenal ulcer. So the one who is elderly with melena and non-steroid anti-inflammatory drug use, this is also drug-induced ulceration until proven otherwise. For the first one, we have to do what? Endoscopy. Even if the patient is not having any pain, even if the patient does not have any complaint, but accidentally we found out the patient has anemia. We need to do endoscopy. Common IMG tasks: identify classic ulcer clues, recognize complication, choose endoscopy appropriately, and start immediate management in the bleeding presentation. Heavy scoring points, no and do. Please, these are the points. These are the points that secure you a lot of score. State the major causes early. Like, is it H. pylori? Is it non-steroid? Which one? Because these two are the most common reason, right? Or cause. Recognize the high yield patterns. Duodenal ulcer, we know the pattern, right? The characteristic picture of duodenal: the patient have pain, wakes at night, or early in the morning, gets better with the food. Usually, if the patient is fat, the patient gets meal every 1 to 3 hours, right? Malignancy is rare. And the opposite is gastric. So in bleeding ulcer station, score by stabilizing first. So if it is emergency, always starts with the ABC. Vitals, IV access, CBC, chemistry, and so on and so forth, which we did discuss it, right? Pitfalls to avoid. Do not forget complications. Bleeding, perforation, gastric outlet obstruction, penetration into pancreatic can be first. Presentation, do not treat presumed PUD without addressing the H. pylori or non-steroid anti-inflammatory drug. So it means if you miss mentioning H. pylori or covering H. pylori or non-steroid, you will definitely fail that. Recurrence remains likely if the cause is left in place. Do not miss the example that most gastric ulcer or biopsy or rule out biopsy. So it means for gastric, the chances of malignancy is higher than duodenal ulcer. So it means you need to do the biopsy for the gastric ulcer. For both of them, you have to do endoscopy, but biopsy is necessary. It's a golden standard, okay? Gastritis. Now, this is exclusively for gastritis. A patient with endoscopy or a biopsy report saying gastritis, asking what it means. Somebody told me that you have gastritis. I had this issue. I went and I did the endoscopy or biopsy, and they just said, don't worry about it. It's not something very serious. You just have a gastritis. So what is that? Now, as a healthcare professional, what is my job? So explain the gastritis in a simple or lame language. Diagnose, separate erosive from non-erosive, identify the cause and consult on irritant and follow-up. Now, heavy scoring points in this station. The definition: gastritis means inflammation of the gastric mucosa, and a non-erosive may be clinically silent and often requires biopsy for diagnose, differentiate type. How many types do we have? Go ahead and explain all of them, which we already did it, right? Management scores highest when cause directed. Test the H. pylori and indicate, when indicated, stop mucosal irritant, which is non-steroid, alcohol, smoking, caffeine, whatever it is. Pitfalls: do not equate any dyspepsia with a gastritis. Many dyspeptic patients have functional disease, so we have to make sure that we rule it out. Do not forget that the chronic gastritis can coexist with nutritional consequences or other pathology such as atrophy, autoimmune disease, malignancy, risk context. Do not promise cure with empiric acid suppression alone when the core issue is which is an unaddressed cause like H. pylori, ongoing non-steroid anti-inflammatory drug exposure. So gastritis, inflamed stomach lining, peptic ulcer, ulcer open scar, Helicobacter is the cause, dyspepsia, bloating, nausea, discomfort, and stress gastritis. Remember the mechanical ventilation. Now, drug-induced gastritis, common station, medication review for abdominal pain, iron deficiency, or GI bleeding. For example, they give you a scenario about 69-year-old using naproxen and low-dose aspirin who now has melena but little warning pain. 69. Melena, right? Identify the offending drugs. Stratify risk. Explain the symptoms may be absent. Symptoms may be absent. Again, I mentioned before, the patient might only come for regular checkup, okay? And build a prevention plan. Heavy scoring points. Lead with the cause. Non-steroid can cause petechiae, erosion, and ulcer through direct mucosal injury plus prostaglandin inhibition. So bleeding or perforation may occur even when dyspepsia is minimal. Know the risk factor, which we know, right? The GI bleeding, the age, the older age, non-steroid, aspirin, steroid, and other comorbid condition. High score management. Stop the offending agents. Switch to safer analgesic, acetaminophen, if it's possible. If not, then they can continue it, but you can add PPI, right? Prophylaxis, PPI for prophylaxis, higher patient, and remember, the entry coating reduced erosion, but not ulcer. This is something that you have to remember it because it might be as a post encounter or MCCQ1 question. Pitfalls. Do not rely on symptoms to reassure yourself. Non-steroid ulcers are often silent until complication happens. Do not forget concomitant aspirin, steroid, or multiple non-steroid when reviewing medication. Do not use H. pylori serology to check eradication status after treatment. That is classic exam mistake. Okay? Do not use serology to check for the eradication result. Now, the last but not least, stress-induced gastritis. So, ICU. If they give you a scenario about the stress, it will be in ICU. Definitely. Why? Because the patient has to be critically ill, or the patient is connected into mechanical ventilation. ICU or inpatient prevention bleeding scenario. For example, a ventilated septic patient. Sorry. A ventilated septic patient develops coffee ground NG tube output. Or ICU, another scenario, or ICU patient needs risk assessment for a stress ulcer prophylaxis. Now, common IMG tasks: identify true physiological stress risk, know who needs prophylaxis, and distinguish this from the routine. Heavy scoring points. Make the key distinction: physiological and critically ill, not routine. Psychological stress. Common high-risk contexts include mechanical ventilation, sepsis, multi-organ failure, major trauma, surgery, severe burn, which we did discuss, right? Recognize the classic phenotype: Cushing ulcer with a CNS injury, raised intracranial pressure, and curling ulcer with a major burn. So these are the two. I think you should have. I think you have these pictures in your notes. Bleeding often painless, and finding lesion are common. Score highly by giving the prevention correctly. Use the anti-acid or use acid suppression in genuinely high-risk ICU. No PPI are potent, but may increase the pneumonia risk. And understand the treatment of bleeding mirror, upper GI bleeding management, but may be less successful. So do not do these stuff. Avoid. Do not confuse common life stress or anxiety with the ICU stress ulcer. That error loses major points. Okay? So when they say stress, it doesn't mean psychological or emotional. It is physiological. Do not prescribe prophylaxis indiscriminately to all hospitalized patients. Identify real risk factor first. Do not forget that the mechanical ventilation is one of the most important exam tested risk factor. Please do not forget this. And thank you. How long was this?